For families living with intellectual disabilities, new treatments can't come soon enough. Here at The Neuro, we're pioneering a new approach to help children with extremely rare and severe intellectual disabilities. Today, I talked to Dr. Carl Ernst, who is developing new treatments using single-patient clinical trials, the first of their kind in Canada. This work is made possible thanks to philanthropic support to the Sandra and Alain Bouchard Intellectual Disabilities Research Program. This was an inspiring and eye-opening conversation, and I hope you really enjoy it. Carl, thank you so much for being here.
Pleasure.
Could you explain for those of us at home who might not quite understand what a single-patient clinical trial is?
Thanks, Anita. It's a great question. So it's very different than what we're used to doing. So normally we'd have a lot of patients with a similar disease, and we'd have a group of people who don't have that, and we would provide some treatment to the group of patients with the disease, and we'd see what happens with the medication we've developed. Mm-hmm. In this case, we'll have a single person, of course, who specifically in this example needs to have a really life-threatening, debilitating disease. So this is not for any kind of person. It's a very unique, it has to be really severe. And then we will design and tailor a treatment to them. And that includes the delivery of the actual treatment to the person here in Montreal. So that's what we're building and is in progress now with different people.
You said life-threatening and debilitating diseases. What is the current reality for those children and their families today?
Yeah, so all of the conditions that we see, there is no treatment. There are symptom management treatments. So let's say the person has seizures or some other type of conditions where we do have medications for that. So those people will be receiving treatments for their symptoms. But what we're talking about here, when we think about these single patient clinical trials, is a treatment directed at the genetic aspect. So it's a genetic medicine, and it doesn't have to be, but that's the case we're working on here, to treat the underlying cause of the disease. That's what we're working on.
If we go back 10 years, this kind of work probably wouldn't have been possible. Can you tell us a little bit about what has changed in science that's making this kind of work that you're doing today possible?
10 years ago, there was a lot of promise. So I would say the concepts of the technology were there, put into animals, tested in little dishes and cells in people's labs like mine. And what happened, 5-6 years ago is that some of these first technologies were put into people with severe and life-threatening disease who had no other choice, and they looked pretty good. So in the case of one disorder I'm thinking of in children, I would not say it's curative, but it was bordering on curative, which was a shocking result to many of us. So it was a genetic therapy targeting a specific disease and targeting a specific mutation or mutations in a specific gene, and it was remarkable the effect it had on the group of kids. So people sort of following that initial, and that was maybe 2016, 2017. Mm-hmm. So following that initial success, people have used that same technology for their different genes, and then now it's opened up into even more exciting technologies that again are always gene focused. So that even as recently as last year, people are using these new genetic technologies to change the genome even in people, and we're seeing clinical benefits from this. It's really really remarkable.
That's exciting.
Yeah.
Can you walk us through the process, what that looks like when a child receives a diagnosis and then going on to potential treatment?
Every single thing we do is a knock on the door from a patient. Every single time. Never have I made something that I thought was kind of interesting or cool. That is not how this works, at least for us. It's a patient expressing a need who wants a therapy. And you can appreciate too, there are people with very sick kids who don't necessarily want to do this, say, this is my child. And of course, that's their right to do that. But there are many people who come to see us and say, we really need help. Is there something that you can do? And is the technology there to move it forward? So for those people, we will collect the cells. We will make the brain-like cells from the child. And then we start working on the genetic therapy. So that's a lot of lab-based work where we're playing with our different tools. And I won't go into all the different details, but it really is remarkable to see how far it has come from, when did I get started? 25 years ago or so, just how much the technology's changed and how well it works. So we don't have a technology problem right now. We have an operational problem and a regulatory problem, I can just tell you. So if people are sitting here listening to this podcast, I think that would be one message that's worth keeping in mind, that the technology is there. Our problem is not technological right now. It doesn't mean it will work for every disease. It's just our issues where I spend a lot of my time is actually not working on the scientific part. That takes, nothing's easy, but it does move forward. Where things are difficult is making sure that everything's set up from a regulatory standpoint, and how do we help as many people as we possibly can instead of just one person walking through the door, for example.
Mm-hmm. So you're mentioning you have to work with regulators, but you're also working with industry. You're also working closely with other hospitals in Montreal, like the Saint-Justin,
Yep.
the Children's. I hear that you get 2 to 3 samples a week. Could you just let us know about that ecosystem, how it's working, why it's important?
When you think of trying to create therapies for a single child in this case, you can just imagine how difficult it is to bring everything together. So there's the family, there's the clinicians who may not be scientists, but who are also desperate to help the child. There's the hospitals like ours here, or the Montreal Children's Hospital, or Saint-Justin Hospital, the University of Montreal. So the expertise that comes together, so I even mean the technical expertise, so my own, theirs, and then the clinical expertise that comes together, it is a massive team of people that is trying to move mountains to advance this for a person. That's really what it looks like. And I have to also say, it's very inspiring, from the parent standpoint, to see them willing to take this journey with us, and then seeing people come together who do have amazing skills and expertise and always want to help, even on other projects. But when there's a single child who has such great need and we think there's a potential we can do something, it's really amazing. And it's the kid that brings us all together too, right? And we can do it. I think that I really want to underline that this is a doable, we're not in a pipe dream anymore. And 5 years, 6 years ago, it would be like, this is something we can think about, maybe we can do, but we're here. And it's almost time to stop talking about, does the technology work? Because the technology works. Let's operationalize this to help more than just 1 or 2 kids a year. That's where my mind is at right now, I can tell you. I don't want to be just one kid. We want to be like, okay, we got these 120 kids that we're working through. That's what I want this to look like in a few years.
You're talking about operationalizing it. We have the technology, funds. We know that a clinical trial often takes in the millions. And your colleague, Thomas Durkin, said that what you're working on could be considered a pipeline. Yes, you're working on one child at a time, but this is a pipeline that could be used again and again going forward. Maybe you could talk a little bit about that.
We do think that sort of pipelining this or platforming this is essential. We're in the middle of this right now. We're about to dose our first patient in September 2026. It's coming. And what we want to do is have that as a template for all children that come after this initial subject. So what does that look like? It means that we don't want to have to redo all the paperwork for Health Canada. We've been through that once. It took us months and months and months to do it. And we're meeting the people there who have opinions too about what it should look like and how things are framed. So when we think about things like platforms or pipelines for treating a single patient, we want to have it set up where we try to think of it in modules. Like, okay, regulatory filing. This is what this looks like. And these things are all similar. These are all unique and different. Every person's going to be different. It's going to be a different medication, that's for sure. But we don't want to have to spend the same amount of time on it the second time through and the third time through. We want to have teams in place where this is A goes to B and B goes to C. And the same thing is true in the lab. If you were to come to my lab and you'd see there's the students working around, they have pipettes in their hands, white lab coats. It looks like you'd imagine, but they each have their own disease and they're making these medications in my lab. It's amazing. And they're like, Carl, this one worked pretty well. This one didn't work. I'm talking about the cells from the kids now. Right? We're not putting anything in a kid in my lab. And if you actually saw that, you'd start to appreciate, like, you guys tell me you got 3 or 4 medicines for this kid who's very sick over here. I'd be like, yeah, we have them. It doesn't mean that this will work. It doesn't mean that it's not toxic. So there's, they need to be assessed and tried. So this doesn't go from lab to human. That's not what we're talking about. But it's amazing that in a few weeks, you have some therapies that could be useful. That's what I mean by the technology's there. And let's say 6 of them don't work, but the 7th one does. I mean, isn't that an amazing thing that we have? So when we think about the platform of the pipeline, we're thinking in terms of patient recruitment. How do they come in? How do they get seen? The sort of triage. How do we decide what mutation gets to move forward? Which is very important topic to discuss. And then where do we grow the cells? Where do we store the cells? Who's making the neurons? Who's going to make the therapy? What company does this come from? What's the next step after you find some promising lead candidates? So each of those is something that, and I'd say it's the embryo of that is in place. What we need is to drive that forward and to get it through in as many kids as we can moving forward.
I've heard the case of one of these children who has 50 seizures a day. So when you are up close to them, it changes what impact means for them. So it's not necessarily curing them. What does success look like for these children and their families?
Yeah, I think how the parents I know would answer that question is, Carl, if the medicine can do something that is meaningful in our life, it matters and it's worth it. So that's how we try to think about this too. We don't think about, so the medicines target the underlying cause of disease. I think that's an important thing to say, but it doesn't mean that it'll necessarily cure the disease. It can, but the reality is it's unlikely to. So some of these are developmental in nature. We're not sure when the problem started or what's happened afterwards. So some of them could be degenerative and progressive too. So we don't know what will happen when a treatment or a genetic medicine goes into the child, or at what point it needs to go in for it to be more therapeutically beneficial than, say, at another time point. Our goal is to think about the symptoms that the parents tell us are important to them. Moving from 50 seizures a day to 25 seizures a day would be a huge win. So for others, they might say, your medicine doesn't stop the seizures. It doesn't do anything except it reduces seizures, from 50 to 25. Well, what's the point of that? For parents is meaningful to them, for example, but the child can still be very sick. I think when we think of outcomes and impact for the kid, we need to think about it in terms of what's important to the person. And if they can't speak or express themselves, what does the parent say is important? And so that is how we guide what we're going to look for when we treat the kid with the medicine. It's what matters to you, and then we will apply the science to what matters to you. So, for example, can we measure it? It needs to be scientific when we're looking at, does this work or not? But we start with what matters to you, and then we will look at those symptoms and just figure out which one we can actually work with. So it's really a patient-focused or parent-focused scientific endeavor. We are not a top-down group. It's really everything's coming from the patient. From here I am, I'm at your door, to this is the symptom that matters to me, and what can we do to measure it and fix it? And they work with us to do it. So it's really amazing how collaborative it is with the families. And it's a journey. Families have to be willing to answer our questions and send the data, and it's a lot, so they want to be involved with us because they think there's going to be a benefit at the end. And obviously we hope the same too, but it's not an easy thing to sign up for one of these, to have your kid treated with the first medication ever made. And, imagine what that would feel like. There's the promise of it, but we just don't know what will happen. So we're on a journey, and we're trying to keep things as safe as we can. But the reality is we're in science, and it's unexplored, and it's risky.
But there is hope, because currently the alternate is nothing.
There is no alternative for them to slow or stop disease. And we're talking some very, very severe cases here. So, I always say we got two rules here. One, we'll be fully transparent with you with what we're doing. And two, I won't put anything into your kid I wouldn't put into my own kid. So it's, as soon as they hear that, they're like, all right, let's talk. Let's work together.
As you said, these are really rare cases. And so the work you're doing is high risk, it's innovative. And if you were to work with sort of regular funding channels, the first question you might be getting is, well, how big is your patient population? But as we know, maybe there's one or two children in Canada, and then maybe 100 across the entire globe. Yeah. So how important has it been to have philanthropic support?
The resources from people who are willing to provide funds of philanthropy are essential to make the work move forward. There's just no other options. There's no industry really isn't interested in rare disease for the most part because of the number of patients, and the government's got so many other priorities. So it's the critical missing middle of the gap that philanthropists are willing to fund. And we're very grateful that they're willing to listen to us, talk to us, and hear what we have to say, and just about how promising everything is. Because we think there's a nice story to be told here, an important one. The technology's there. I think for many people we talk to in the philanthropic community, like, what, Carl, you can do this? You just need like resources to move this forward. That's the conversations we're having. It's like, we can do it. It's a matter of, significant resources, but not extreme. And when we talk about things like pipelining and platforming, you can start to see how if we start to pool resources, we can have something kind of special with respect to treating the rare disease community from a genetic medicine standpoint.
If you were to speak to a donor directly right now and tell them about their impact, what would you say?
First, I would just say I would thank them for, being willing to come to the hospital and to contribute their hard-earned money to, us more generally, and then this rare disease genetic medicines area more specifically. I would say that, for every dollar that goes into this type of work, the impact is significant. We are not in a place where let's take some money here and maybe we'll have something in a few years. Like, that's not the conversations we're having. Conversations we're having is, and there's a lot of people we speak to, it could be business people or so on. They know what they're talking about with respect to what do you need and what are you going to get done. We can have that conversation. We're kind of a different area of science. I like to think it's like, well, this is what's going to happen first. This is what's going to happen second. This is what's going to happen third. And this is what's going to happen fourth. And it could be this many people. It could be that many people. And it's a very, systematic discussion that can be had. And I think for certain types of philanthropists, at least, it's a nice discussion to have, like, okay, I can understand. I don't maybe understand every last little detail you say, Carl, but like, I understand that you're going to go from A to B. And I understand you need this much to go from A to B. Is that something that I can do? Or what do you need? Like, it's a nice conversation. Now, for us, and I think oftentimes for them.
And looking ahead, what is your vision for the future in terms of clinical trials, developing therapies?
Scale. So like I said, we're scale and operationalizing. We're at the point where we know we can do this, and who's willing to take this journey with us to go big. Like, it's the moonshot now. So we can sit back and we can wait, and we can have the Americans or somebody else do this, and it may be city specific, of course. Or we can say, you know what, let's just do this. Maybe that means a big building for genetic medicines for anybody, where we're just developing and designing treatments. So I think the future is bright, but I think people need to understand what would be involved in moving this forward. But again, the impact, the cost benefit on the resources that go in, and then looking at what comes out it's pretty significant, for people willing to take the risk to move this forward. We want to operationalize and scale. That's the conversation we're having now, not can we do this?
Carl, that's amazing. Thank you so much for sharing your work and your vision. And thank you to the donors too, who are funding this important work and bringing hope to children and their families facing the toughest neurological conditions.
Thanks to you too, Anita. Nice to be here. Thanks.